Hello, everyone. My name is Lourdes. Welcome to our Thursday webinar series. Glad to have you with us today. As a reminder, please put any of your questions into the chat or the Q&A so that we can capture them there, and then we will have the Q&A session at the end of the webinar. Remember to please make your questions general in nature and not specific to your case, as our speaker cannot specifically answer those questions. And to introduce our speaker, Jenna O'Rourke is a board-certified nurse practitioner specializing in gastrointestinal medical oncology at Beth Israel Deaconess Medical Center in Boston, Massachusetts. She is also a member of the Nursing and Allied Health Professionals Advisory Board for the Cholangiocarcinoma Foundation. She first started her oncology career as a bedside nurse, taking care of surgical oncology patients, and has now been caring for patients as a nurse practitioner for nearly 5 years. Her love for medical oncology and the care of patients with cholangiocarcinoma is growing every day. She thoroughly enjoys getting to know patients and their families while helping them navigate some of the most challenging moments in their lives. Thank you for being here.
Thanks, Lourdes. Hi, everyone. Thanks for joining on this Thursday to talk about immunotherapy. Like Lourdes introduced, I'm Jenna O'Rourke, and I'll be talking about all things immunotherapy today. I'm proud to be a nurse practitioner at Beth Israel Deaconess Medical Center in Boston, as well as serving on the Cholangiocarcinoma Nursing and Allied Health Professionals Advisory Board. I may have met some of you there at our annual meetings, and this is my third webinar, so happy to be back. Thank you so much, and let's get started. No disclosures today. All right, so today, webinar learning points, we're going to talk all things immunotherapy. So we're going to talk about what immunotherapy is. We're going to talk about side effects that may be present with immunotherapy, treatment options for when side effects happen, and when to use immunotherapy in the setting of cholangiocarcinoma. So this webinar is geared towards patients and caregivers. We will talk a little bit more high level today than some of my other webinars, just with the nature of the topic, to dig in a little bit. So, well, let's get started. So what's immunotherapy? So immunotherapy is also referred to, we'll be talking about today, a type of immunotherapy, immune checkpoint inhibitors. So immunotherapy, kind of big picture, would be to use the body's own immune system to fight cancer. So our body has immune cells. Immune cells are helpful to fight infection, but also to fight cancer and identify cancer. And in broad strokes, immunotherapy is administered generally through an IV, and it's going to teach our own body's immune system the instructions for how to recognize cancer cells and to kill them. Immunotherapy is going to work in the moment, but also works for time after the infusion is given. And so it is a gift that keeps on giving, to be able to allow the body's immune system to know how to look for those cancer cells in the body and to be able to attack them and kill them. So this is an in-depth photo here to kind of describe a little bit of the pathophysiology, or the kind of mechanisms behind how the immunotherapy will work, or how the immune checkpoint inhibitors work. So the picture here is depicting our body's immune system through a T cell, the blue structure, and a tumor cell, the orange-brown structure here labeled. Both of these cells are going to have a protein expressed on them. The T cell, the immune cell in our body, has a PD-1 protein, like a little, find me structure. And the tumor cell is going to have a PD-L1 protein attached. And when the immune system is working adequately, it's going to be able to recognize cancer cells. When the immune system fails, cancer can grow, cancer can occur because of mutations and tumor growth. So, how this happens, we have our T cell, as I've said, with the surface protein, and the tumor cell, which has the surface protein. These two can connect. And when these two connect, the PD-1 and the PDL-1, the tumor cells hide. And so our immune system can't find the tumor cell. It's like it's kind of has a cloak on, and it's hiding essentially. The T cell can't look for the cancer, it can't fix it. And so, one cancer cell could be taken care of by our body's immune system. But if the immune system can't find that one cancer cell, then tumor cells or cancer cells are going to continue to rapidly divide, and they're going to grow, and they're going to make tumors. And so, with immunotherapy or immune checkpoint inhibitors, we can try to prevent the tumor cells from hiding from our immune system. And the way we do that is we're going to try to prevent PD-1 by binding to the PDL-1 protein. So we're going to try and break this connection. And when the immune checkpoint inhibitors break this connection, the tumor cell can be found again. The immune system can recognize the tumor cell as something abnormal or something bad, and it can do its job to take care of it and hopefully to kill cancer or stop cancer growth or stop cancer spread. These are some examples of immunotherapy that are in practice today and FDA approved today. This is a chart. This is a chart for just kind of depicting what immunotherapy has evolved to be over the years. So if you see in 2011, really the only indication for using immunotherapy would be melanoma, a type of skin cancer. And so over the years, we've been able to find different ways to use immunotherapy across many different types of cancer varieties. And, this chart stopped at 2020, and we're, of course, 5 years from that point. And so we have even more indications now, including our biliary tract cancers, which are not even labeled on this chart. But this was a good just kind of way to show that, immunotherapy has evolved drastically over the years, and we have so many more indications and so many more opportunities to use immunotherapy to treat cancer. So, in terms of the balance, so we'll talk a lot about side effects. So there's a balance for sure. Immunotherapy is wonderful to be able to give people time off of chemotherapy, to improve survival of diseases and to improve tolerance through less toxic regimens, less side effects from chemotherapy, essentially. However, it does not come without risks. Immunotherapy definitely has risks. Those risks for major life-threatening challenges or side effects are there, and so we're going to balance chronic toxicity and side effect or life-threatening toxicities or side effect with the benefits. And that's a discussion with your healthcare provider. Not all people are eligible to receive immunotherapy. Side effects. Actually, let's just talk about that because I don't think I have a slide. Not all people are eligible to receive immunotherapy. So immunotherapy is definitely a decision between you and your healthcare provider. Some people are at risk for developing major immune-related problems if they have an autoimmune condition. So if you have an autoimmune condition, depending on the severity, your healthcare provider may determine that you're ineligible to receive immunotherapy. All right, so broad overview of side effects here. So immunotherapy is going to work differently than chemotherapy, and so the side effects do have there's a different side effect profile. So chemotherapy is designed to kill cells, kill rapidly dividing cells. Chemotherapy is used to kill good cells in our body and also to kill cancer cells, the bad cells in the body. And of course, chemotherapy, when doing that, is going to cause major side effects. That's a whole nother topic. So, you know, as a patient or a caregiver, I'm sure that you can um, think back to a time in which you or your loved one had experienced side effects related to chemotherapy, like mouth sores or blood work changes that required treatment holds, nausea, vomiting, diarrhea, bowel changes, um, lots of things. And so immunotherapy is different because it's not killing the good cells in the body. It's not killing cells at all. Directly. It's teaching the body's immune system how to identify cancer cells and to destroy them. So immunotherapy has a different kind of side effect profile, and so it's important to note that not everyone will even have a side effect to immunotherapy. So a person that receives immunotherapy may never ever get a side effect. Um, there are side effects that can happen, and they're kind of on a scale of very, very mild side effects to very, very life threatening side effects or very severe side effects. So, side effects would be interchangeable with the term immune related adverse effects, and it's also, a way if a provider says, oh, you have a toxicity from your immunotherapy. So all of these terms you may hear in the day-to-day language in your oncology clinic. We've talked that not all people getting the immunotherapy are going to experience side effects. Some people never have a side effect at all. It's also important to note that side effects can happen at any time. So side effects are not necessarily they don't necessarily have to occur when a person is actually in sorry when a person is actually receiving the infusion. They may occur months later after completing therapy. They sometimes can occur years later. If a person has had immunotherapy, it's important that if you're ever um, in the hospital for something, or you ever are somewhere else where you're receiving medical care and the providers don't know your history, that you do say, I've had immunotherapy, because it's always important to think about possible side effects that could be related to the immunotherapy that was given at any point in a person's life. Side effects are also not dose dependent. So, it's not that after several doses of immunotherapy, a person will develop the immune related side effect. You can have one dose of immunotherapy and develop the side effect. Unlike chemotherapy, where we talk about cumulative side effects or cumulative toxicity, a good example for that would be like neuropathy. Neuropathy with cisplatin would be expected to worsen over time. Side effects related to immunotherapy can come at any time. So they can affect the entire body. The side effects can affect skin, bowel, hormones, any organ system in the body. They can occur when the immune system is essentially in overdrive. So we talked about the mechanism of immunotherapy, where it's kind of trying to ramp up the body's immune system to be able to teach our body's immune system how to recognize the cancer cells. Well, sometimes the immune system gets a little bit too excited, or a little bit too ramped up, and it starts to attack healthy organs or healthy cells in our bodies. And so that would be similar to what an autoimmune condition would be. It's the body attacking the body. Not all side effects that happen with immunotherapy require stopping the treatment. We'll talk about that a little bit. The main treatment when side effects present and they are dangerous or do require treatment would be steroids. So the drug class corticosteroids are widely used in treating immune-related side effects. We also have other medications, other kind of antibodies that help with treating the side effects as well if steroids don't work. Possible side effects. So I've pulled this figure from the NCCN guidelines. I give this to patients who are getting immunotherapy. It's just a good kind of graphic here, which explains that every organ can be affected. It's scary when you look at it because there's a lot going on, right? Um, Not everybody's going to experience a side effect. Um, the most common side effects would be side effects of the skin. Um, I have another slide about this as well. But it's just important to know what to look for and to know when to talk to your healthcare provider about possible side effects or possible toxicities that would maybe warrant some treatment or at least some further workup. So, the key to managing side effects would be early reporting of symptoms. So, patients and caregivers, for you, it's really important to know when to call. Um, I tell my patients, don't wait for your next visit in 2 weeks to tell me about your new um, extreme fatigue where you can't even get out of bed. You were previously working and now you can't even, get out of bed. Don't wait for 2 weeks to come to the clinic to tell me about that. I want to know about that right away, right? Because we want to be able to assess that early and treat and potentially treat early. So, when a patient reports a symptom, then also early assessment from a healthcare provider and early intervention and treatment. So, there are things that are not, there are symptoms that can be caused by a variety of things. So, not everybody's excessive fatigue is related to immunotherapy side effect. It could be related to infection, it could be related to a lot of other things. So, you know, we as healthcare providers would do a thorough investigation into a patient's symptoms. We do a physical exam. We take of course, listen to the patient's symptoms and when they started and kind of how they are and if they're getting worse. Um, Potentially imaging. In some cases, a side effect can be, imaging may help. In some cases, we may need to do some procedures like a colonoscopy or an endoscopy and blood work as well. We can monitor for some side effects, so we can kind of track some side effects while a person is receiving immunotherapy. So, routine blood work for any treatment is generally a complete blood count and a comprehensive metabolic panel. That will be kind of routine. So, in those, we're checking the kidneys, we're checking the liver, um, we're checking the blood counts, of course, to make sure a person's tolerating all of their treatment. Um, but in those in specific, the kidneys and the liver, we, sometimes can see elevation in these tests or abnormalities in these tests, which can cue a healthcare provider in that there might be some kind of immune related side effect going on. Um, one abnormal result would not be uh, one mild abnormal result may not be reason to stop your immunotherapy that day. Um, but ongoing trend of, you know, kidney blood work abnormalities or liver blood work abnormalities may may end up requiring some further workup or stopping the treatment to evaluate for improvement. We can also monitor thyroid function. This is part of the guidelines, the NCCN guidelines, to monitor thyroid function tests every 4 to 6 weeks while a patient is getting immunotherapy. Thyroid dysfunction or hypothyroid is one of the main side effects as well for immunotherapy related side effects. Um, we can catch this early. So thyroid function, generally, we're checking the hormones. Sometimes we can see that a person has hyperthyroid first, And that would be a clue that probably the immunotherapy is causing this, and they're going to be hypothyroid pretty soon. So that's why we kind of check, because we know that this probably, is a common one to happen, and we can treat that with just giving some thyroid hormone. And so another, part of the vital signs we check for is oxygen saturation routinely. This can be a helpful one to clue providers into any abnormalities in breathing. Lung toxicity generally manifests with trouble breathing. Most people with a low oxygen saturation are going to have some sort of symptom associated with that. But it's also helpful to check, routine oxygen saturation when they come into clinic might be like 91 when the person is normally coming in at 97 or 98%. Maybe they're not feeling super short of breath just at rest, but they may have some shortness of breath with activity or walking. Like everything else, it could be a lot of different things. It could be it could require some investigation, but the oxygen saturation could definitely clue a provider into thinking about the immunotherapy as a culprit. Referral to specialists might be necessary as well. So, the work that we do um, is collaboration is key. And so we may reach out to colleagues depending on resources available in your institution, colleagues that specialize in dermatology, that specialize in cardiology. Some cancer centers have specialists that specialize in dermatology related to oncology. And cardiology related to oncology, and so even better. But sometimes we need to kind of pull in more heads to be able to kind of think about what's going on and how to treat the person best, and help them with um, symptoms, but also treating potential immune related toxicities. Um, I'll go. Well, so here in this chart. Actually, no, we'll go here. Possible organ systems. So a little bit high level here in some of the wording, but most common side effects are going to be the ones that I started. So endocrine, which would be hormones, thyroid, the adrenal gland, pituitary gland. Um, a patient, we've talked about thyroid, but a patient with adrenal insufficiency might report excessive fatigue. Patient that comes to mind that had adrenal insufficiency was a teacher, worked Monday through Friday, didn't have a problem going to work, then reported that they, needed to get carried out of work because they couldn't even walk. They were so fatigued, right? It's not just like, oh, I feel like I need to um, take a nap. My nap is 45 minutes and then I'm great for the rest of the day. Normally, this is profound fatigue, but important to let your provider know if you're having any changes in energy, of course. Other most common body system, skin is actually one of the most common body systems to be affected. So cutaneous or skin, rash is super common. So rash, definitely has other causes as well. But if a person's on immunotherapy, then rash can be possible. Often self-limiting, meaning doesn't alter life drastically. Um, Sometimes it can be associated with itching, sometimes it does not. Sometimes it kind of comes and goes. Sometimes the rash is present um, kind of continuously throughout treatment. Dermatology is a great resource. So, seeing a dermatologist, some skin findings can be severe. And so, some skin findings might require a biopsy, and that would be done generally through a dermatologist. Um, a lot of times, like a steroid cream can help um, with rashes. Um, some skin toxicities do not require treatment holds. The thyroid stuff, a lot of that does not require treatment holds. I say this with a little kind of like asterisk because, of course, there are outlier scenarios, and maybe some of you have experienced, but there's always going to be the outlier in which the thyroid, is completely out of whack, and really it's a bad situation, and a person is hospitalized, and in that case, immunotherapy is definitely held. But for the non-outlier scenarios, um, generally thyroid stuff and these kind of like milder skin reactions you can proceed with immunotherapy. The GI tract, so gastrointestinal, so another common body system to be affected by immunotherapy, diarrhea, or inflammation of the bowel called colitis, or inflammation of the liver called hepatitis. So, risk factors for developing immune related adverse events or side effects. So, we're working on figuring this out. We don't know. Um, we don't have great information about who might be at risk for developing side effects. Research is ongoing. We there may be an increased risk of immunotherapy side effects when immunotherapy drugs are used in combination. Um, so two immunotherapies together. And we talked about, a person that already has an autoimmune condition. If that person was deemed a candidate for immunotherapy, then they're not only at risk for their autoimmune condition flaring, they may also be at increased risk for um, immune related adverse events or side effects. But I think kind of moral of the story from this slide is that we really don't know. We can't predict somebody coming into clinic and we give them pembrolizumab or durvalumab. We can't really predict that they're going to have a side effect, which can be hard. Um, Continuing treatment versus holding treatment. So this is the big question. Can I still get my immunotherapy today? So not all side effects require a treatment hold. We've talked about that a little bit, but some do. Um, some side effects can be extreme. Some side effects can be life-threatening. Some side effects can lead people to be hospitalized. The goal is to avoid that. How we can avoid that in some scenarios would be early reporting of symptoms. So I'm going to really drive home on that one. Early reporting of symptoms is helpful. Sometimes that's unavoidable, and there's a really severe side effect that, we weren't able to catch early at all. Okay, so we use this kind of tool, the common terminology criteria for adverse events, and we use this tool to help grade immunotherapy side effects or immunotherapy toxicities. Grade 1 would be a mild side effect, all the way to grade 5, which would be death related to the toxicity. And so this is helpful for guiding providers as to when it's necessary to hold treatment, or to continue if they can continue treatment. So example here we are in the GI world with cholangiocarcinoma, so why not talk about the GI system? So this is the CTCAE kind of chart for diarrhea. So diarrhea, we want to always be mindful with any symptom of what the person's baseline is. So a person might have, two bowel movements a day that are watery, and that's just normal for them. Um, we are looking at, for grade 1, which would be kind of the mild category, we're looking at an increase of less than 4 stools per day over the baseline. Um, Grade 2, as you can see, 4 to 6. Grade 3, greater than 7. Grade 4 would be life-threatening. Generally, these people are in the hospital. And grade 5, death. So, a helpful tool to be able to kind of characterize a person's symptoms. And we have lots and lots of symptoms to be able to grade to help guide treatment decisions. So example here, just kind of continuing on with the diarrhea the diarrhea example. So we'll talk about our mild grade 1. So this is kind of um, how I would think about it if I was treating a patient um, with new diarrhea or worsening diarrhea. So um, generally, we're not going to jump to immunotherapy as the immediate cause, right? We are going to first assess for something else that might be going on. Maybe there's infection, maybe there's enzyme disruptions from the pancreas, maybe the person has a viral illness. Um, we don't, we want to think about immunotherapy, but we're not going to jump to immunotherapy as the only cause for a symptom. Management, can be supportive, such as hydration or dietary modifications, close monitoring. I say this because, a person with a new symptom, generally you want to follow up with your provider within the next few days to make sure that your modifications are helping. So if you've followed a brat diet with, just bland foods and your diarrhea is getting worse, then, you should call in again. And that um, kind of goes hand in hand with close monitoring and early reporting, is just making sure that you're telling your healthcare provider when symptoms are not getting better, because that can definitely raise a red flag for maybe immunotherapy is at play. Grade 1 side effect, we may consider holding the immunotherapy that day, not discontinuing it in entirety until we kind of figure it out. Excuse me. As a general um, kind of statement, immune related side effects don't just get better on their own. Immune related side effects do get worse if they're not treated, but generally would start to get better only with treatment from steroids, if or antibodies, if steroids don't work. So now we'll move into the grade 2 aspect. So this person's now having 4 to 6 stools over baseline. If their baseline is 2, that's a lot of stooling. So person's definitely at risk for dehydration. So we're going to continue with our supportive care and hydration. We're going to continue to evaluate for other causes, but we're going to definitely think about if this could be related to immunotherapy. So there's some lab testing that we can do to kind of determine if immunotherapy might be out at play. One of those tests would be a stool test. Um, it's called a calprotectin. So we would essentially look for how much kind of inflammation there is, because inflammation is going to be kind of the main driver of these symptoms. Remember, the immune system is ramping up and going into overdrive. It's hyperactive. It's causing inflammatory changes, and so inflammation can be picked up in a stool test sometimes. Um, we can consider imaging, depending on, you know, how quickly one can get an image. Sometimes this can be helpful to be able to look for inflammation in the bowel. Sometimes it cannot be helpful. And so if a person is having lots and lots of diarrhea, but the CAT scan looks normal, then you're still gonna, have a red flag raised for as that symptom might be related to immunotherapy. We can also consider collaboration with colleagues from GI, again, pending resources available in your institution and how quickly a GI provider can see a person um, for a colonoscopy. Colonoscopy would be great in in theory if you can get it like tomorrow, and um, we can get a biopsy and we can see if there's inflammation, maybe related to the immunotherapy. But that's a perfect world, and in healthcare, we are not in a perfect world in many circumstances, and so a lot of times this is not possible. Management for grade 2, we would generally hold the immunotherapy based on guidelines. We would start steroids. The steroids are designed to calm down the inflammation. We can also consider other antibodies that can be added to the treatment, um, like infliximab is one, if the steroid does not help the calm down the inflammation. And again, co-management with specialists, so involving GI um, in the scenario as well. Severe diarrhea, grade 3, grade 4. So this is definitely getting into life-threatening scenarios where the person is having such severe diarrhea, lots of inflammation potentially going on in the colon, lots of risk for side effects related to how much bowel movement a person would be having. We're thinking about, dehydration definitely, but also we're worried about electrolytes in the blood and um, uh, like low potassium and potential like cardiac complications from that. So these people can be in the hospital. Um, of course, we're going to still look for infection. We're going to, still look for other causes, but we're gonna definitely be on steroids here. Um, a lot of times IV steroids would be indicated. IV is quicker than oral. It's we're able to watch a person in the hospital environment. We're able to monitor their blood work. We're able to monitor their symptoms. We're able to support them through dehydration and blood work abnormalities. This would Generally speaking, grade 3 or grade 4 side effect for diarrhea would require discontinuing the immunotherapy. Okay, so case study here. Um, so patient AM has intrahepatic cholangiocarcinoma and is receiving treatment with Gemcis and Durva. He's received 5 total doses of durvalumab so far. He calls his oncology provider because he's having some new diarrhea. So first, good job to AM for calling for the new symptom. So he's coming to clinic for the evaluation. He's having 5 episodes of diarrhea per day. Normal is one formed bowel movement. He lives with his spouse, and his spouse is feeling well. His spouse is not sick. AM has some abdominal cramping associated with the diarrhea, but that resolves after going to the bathroom. And he feels tired, but otherwise is at baseline. So, based on what we've just talked about, this would be grade 2. Um, we are going to look for blood work and stool sample, maybe check for infection and that calprotectin. We're going to manage dehydration, supportive care, depending available resources. We might try and get a colonoscopy, but generally we'll be starting steroids then and there. Um, so close follow-up is important. So with AM, we want to make sure that symptoms are getting better and they're not getting worse. Once we put him on steroids, the diarrhea should improve. If it's not improving in 3 days, then we're going to look for some help from our GI colleagues for maybe starting infliximab, which is an antibody to also help calm down inflammation, and continuing the steroids too. So, stopping steroids in immunotherapy related adverse events. So, steroids, like we've talked about, they're designed to calm down inflammation, but we can't just abruptly stop them. We can't abruptly stop them in any scenario that we're using steroids for. Um, when a person has received steroids for greater than like 2 weeks. Um, so we taper steroids down, and oftentimes the taper is extremely slow. The steroid doses are pretty high. So, we could be seeing steroid doses at like 60 milligrams of prednisone a day, sometimes higher. Um, that's a lot of steroid. Um, Steroids aren't lovely. They're not fun. They come with side effects themselves. They're gonna make you not want to sleep. They're gonna make you moody. They're gonna make your blood sugar go up. They're going to cause a lot of fluid retention or swelling, sometimes in the face, the legs. Steroids are not fun. Steroids cannot be stopped, just kind of cold turkey. So they definitely need to be tapered. The taper for immunotherapy related side effects is generally very slow over several weeks. Sometimes it can be over months. If symptoms, if the taper is too quick, then the symptom of the immunotherapy side effect can come back. So um, the diarrhea, once is well controlled, we can start tapering that steroid down, but we're going to do it slowly. So we're going to do it over several weeks. And if it's going to get worse again, we may have to go up to back where the person just was. Okay. Can we start immunotherapy again in the future? So this is like $1 million question. Sometimes, sometimes we can, and sometimes we can't. Um, so it really depends. Joint decision making with your healthcare provider for sure. It really depends on the severity of the symptom as well. If a person's having immune-related heart toxicity, no, we're probably not going to be trying the immunotherapy again. If the person's having immune related joint pain that ends up being well managed after stopping steroids, they've been doing fine. It wasn't a super severe symptom that landed them in the hospital, then maybe we can retry. That's again a joint decision, and everybody's situation is different. So there's no blanket statement for this one. Um, so I find this graph interesting. Um, when rechallenged with immunotherapy, 48% of people did not have any other immune related side effects. 26% had that same side effect pop up again, and 26% had a different side effect pop up. So about half of people did totally fine. But again, it's a joint decision and it's based on symptom severity. So if a person is in the hospital, or if it's a immune related side effect affecting an organ system that it can be life threatening if occurs again, then no, you're probably not going to be getting the immunotherapy again. This is a really in-depth slide, high-level slide, but I just wanted to kind of talk as an overview here as to if we can predict if a cancer is going to respond to immunotherapy. So a healthcare provider might call that predicting response. So there are certain tumor characteristics that are helpful to predict if a cancer will respond to immunotherapy. In some cancers, we check if the PD-L1 is expressed and how much is expressed. Not the case for cholangiocarcinoma. We don't have to check that to be able to use durvalumab, but in some cancers we do. The higher the expression, the better response. We also can check a tumor characteristic called tumor mutational burden. This is essentially looking at how the tumor is made up and how many mutations it might have. The higher the mutation burden, or the more mutations a tumor might have, the better response to immunotherapy. The way to maybe think about this would be that tumor is very unstable. That tumor is highly mutated. It's super unstable. If we introduce something like immunotherapy to it, it's probably going to respond well. I guess maybe that unstable scenario wasn't a super great one in the setting of this next microsatellite instability. So again, kind of thinking about kind of the instability of the tumor. High level on the right hand side here. These are a lot of things that are undergoing research, and hopefully more to come in coming years, looking more at the tumor characteristics and environment, looking at, you know, other mutations involved in the tumor, um, looking at the person's GI tract and the gut. I think there's a lot of research in kind of the gut microbiome in a lot of areas of healthcare right now. Um, Looking at if, certain intestinal flora or gut flora could be a good predictor of immunotherapy response. Um, and this last one um, can be a blood component. But again, more research to come, which would be great in coming years. Immunotherapy and cholangiocarcinoma. Um, so the turning point in cholangiocarcinoma came when the FDA approved durvalumab in 2022 to treat locally advanced and metastatic biliary tract cancers, including cholangiocarcinoma. So this is a huge step forward in the world of treatment for cholangiocarcinoma, which is amazing. Um, so the Topaz 1 trial is the trial that allowed this to happen. So we used durvalumab in combination of chemotherapy, gemcitabine and cisplatin. And the Topaz 1 trial found that durvalumab plus chemo significantly improved overall survival, which was amazing compared to chemotherapy alone. And the 3-year follow-up data has come out showing that durvalumab and chemotherapy combination doubled overall survival at 3 years compared to chemotherapy alone. So this is the current recommendation, which is NCCN from the NCCN guidelines for unresectable and metastatic cholangiocarcinoma. And we're very happy to have immunotherapy as an opportunity in treatment of cholangiocarcinoma, and hopefully we'll be able to use immunotherapy or other immunotherapies or in different settings in the future of cholangiocarcinoma as well. Two other immunotherapy or 3 other immunotherapies here to note. Pembrolizumab is approved to be able to use in a microsatellite in stable cancer. So it's a tumor characteristic that would need to be checked called MSI high. Microsatellite stability we're checking for, and if it's high, then pembrolizumab would be possible. And then if there's a lot of mutations in the tumor, in some cases, ipilimumab and nivolumab would be used. Generally, this is not going to be as a first option, though. It's going to kind of be in later lines of treatment. Okay, I think that is all for my presentation. Questions?
If anyone has any questions, please enter them into the Q&A or the chat. We do have a couple. Have you seen women having an increase of facial hair during immunotherapy treatments?
Personally, I have not. I don't know if that's in theory, it could be related to hormone imbalances.
Okay. I know you mentioned already some of the immunotherapies that are used for cholangiocarcinoma. In terms of side effects, are there, and I know you had a slide over side effects, but are there any that are specific to cholangiocarcinoma?
No. So we on one of my slides, about we can't predict the side effects. Immunotherapy side effects, although immunotherapy is the gift that keeps on giving in terms of being able to, have great response towards treating the cancer, side effects are non-selective. So we don't know if cholangiocarcinoma is going to be more associated with having skin side effects versus heart side effects. In the different immunotherapies that are used across cancer types, there's a little bit of a different profile of side effects of like which um, organ groups, organ systems are more affected compared to others, but not cholangiocarcinoma, not disease specific.
Okay. Can you go back to the other slide? Somebody's just asking to see the last slide.
Oh, sure.
And then is the
Oh,
rash or
I forgot
itching?
about this
Oh,
too.
perfect.
Can I pause for a moment, Lors? Sorry. This is wonderful. So, resources for patients and caregivers. The NCCN guidelines, if you, as a patient or caregiver, haven't gone to the NCCN guidelines, um, they have patient information for almost every disease group and also immunotherapy. Um, and also, like, blood work changes and a lot of other things too. NCCN guidelines for patients, I find this extremely helpful and a lot of high quality information. I highly recommend this um, instead of just Googling. Especially now in the world of AI, where you're getting a lot of information pulled from a lot of different Google articles. Not everything is completely accurate or the best information you could be getting. Highly recommend the NCCN guidelines. Maybe Lourdes can send out the link for this. And then the immunotherapy website from the American Cancer Society has a nice video um, for immunotherapy for patients as well. So I like that. Sorry.
No, perfect. Thank you. Um, there was a question regarding the rash or itchiness. Is that generally all the entire body, or could it just be certain areas?
Um, It depends. I've seen it on the entire body in just kind of like spots. There are also so many different rashes, right? So it's not just like one rash that can be present with immunotherapy. Um, there are there are hundreds of rashes that might be related to immunotherapy. Um, some people can get a whole body rash. Some people can get like a torso rash. Some people can get just kind of like sporadic little red dots I've seen. On mostly their extremities, sometimes their torso. There are hundreds of rashes related to immunotherapy.
Can immunotherapy affect the bone marrow and decrease blood counts or platelet counts, or is this caused more by the chemo?
Yeah, so that's generally caused by the chemo. That's a really good question and helps to depict side effect differences between immunotherapy related side effects and chemo related side effects. So, um, bone marrow is affected by chemotherapy. And so when we're killing cells, the cells are produced in the bone marrow. And so that's a chemotherapy related side effect mostly.
Is weight gain a common side effect?
Not a common side effect. If there's a if there's hormone imbalances such as like hypothyroid that's really uncontrolled, or other endocrine abnormalities that are really uncontrolled, then yes, weight gain would be possible.
Um, is it common for the lab to refer the patient to their family doctor for developed thyroid issues instead of treating it themselves with levothyroxine?
In my practice, if we cause the immunotherapy related side effect, then we treat it with the help of maybe some collaboration from other providers. Maybe other practices are different.
Perfect, thank you. Have you seen severe cases of psoriasis? And if so, what treatments were effective in combating the severe plaques and scales that were
Um,
manifested by the immunotherapy?
so, if I guess it was an immune therapy side effect, severe psoriasis, you probably would go to dermatology and maybe get a biopsy to make sure it was you know, um, it was psoriasis. And I mean, there are, topical options for treatment of psoriasis, but there are also infusional drugs that can be used as well. I think that's, I'll give that broad answer.
Do side effects
I
generally
think
come on
to go back,
slowly?
steroids, if it was steroids as well can be used orally. Sorry.
Okay, no, that's fine. Do the side effects generally come on slowly?
For immune related side effects, generally, no. It's not like a slow ramp where you're having, I'm going to give the example of diarrhea. Like you're having 2 episodes of diarrhea this week, and then in a couple weeks you're having four, and then a couple weeks you're having six. Generally, the symptoms um, will continue to get worse if left untreated. Um, Generally speaking, if a person is having an immune related side effect, more immunotherapy would also worsen it. So, not a super slow um, onset of symptoms. We've talked about diarrhea, but get to give another example. Pneumonitis is possible, so lung inflammation. Any organ system can be affected. If a person has sudden onset shortness of breath, um, that would be a red flag for immune related symptom. It wouldn't be, oh, over the last 3 months, I've noticed that I've had, a little bit of shortness of breath when I'm walking. Um, but, of course, want to evaluate that too. But immune related side effects generally are a bit more abrupt.
Okay. You said that PD-L1 expression is useful only in certain tumors. Can you provide more details on when it's useful?
Yeah, sorry. I think that I said that, and that was easily misinterpreted. So I'm going to try and go back to the first slide here. So PD-L1 is expressed on all tumor cells. PD-1 is expressed on our immune cells. Um, some cancer types require checking for how much PD-L1 is expressed on the tumor cells to be able to utilize the immunotherapy, um, based on guidelines and insurance approvals, like based on research. And it's not that the PD-L1 is not expressed per se. It's just that some guidelines and indications for using immunotherapy require checking the expression of PD-L1 and to be able to use the immunotherapy.
Okay. With regards to side effects in the GI tract, is severe gas one of those side effects from immunotherapy?
Mm, I wouldn't I wouldn't I wouldn't attribute severe gas as a side effect to immunotherapy. Could be related to something else.
Okay. Are patients given the guidelines of how to treat individual side effects?
So, if there is an immune related side effect, then that side effect generally requires steroid treatment. Immune related side effects that are um, moderate would not get better on their own, and generally steroids are recommended. Um, Little asterisks would be a rash, and thyroid abnormalities, in which we can replace the hormone for the thyroid abnormality, and potentially with a rash utilize a steroid cream. Um, but generally, a, if a person is known to be having an immune related side effect or toxicity, we wouldn't just say, go home and manage this on your own. We would prescribe steroids. We would give explicit instructions as to how many pills to take, when to taper down, post follow up.
Okay. Do you know anything about how effective immunotherapy is alone after the 8 cycles of the Gemcis Durva, or if there's any
Yes.
data out there on that?
So in our Topaz 1 trial, we use gemcitabine cisplatin plus durvalumab for 8 cycles, or about 6 months, followed by durvalumab maintenance. Um, it's it's hard to say when a person's cancer might grow again on the durvalumab maintenance. Um, we don't have great information to predict how long durvalumab maintenance might work for. Um, you know, we would hope that it would work for several months or longer. Sometimes that's not the case.
Okay. Um, are there any age limits with regards to the Gemcis durva? And then based on age, can patients request just immunotherapy over the chemotherapy?
Well, durvalumab on its own um, was not studied, so we wouldn't know if it would be effective um, to treat the cancer on its own, and that might be lead that might allow a person to be susceptible to getting a side effect, an immune-related side effect, without benefit of treating the cancer. Um, we know that there's indication to use durvalumab after going through the 8 full cycles or the 8 cycles, or about 6 months of Gem-Cis. So I don't think that one would offer just durvalumab only without chemo. However, circumstances may be different if there's a high tumor mutational burden or microsatellite instability to get immunotherapy on its own, yes. Um, is age limiting the use of durvalumab? No. Can age limit the use of gemcitabine and cisplatin? Yes. It really depends on performance status, which is a fancy way of um, just saying how functional a person would be in their day-to-day life at home. It also, lots of lab abnormalities can play into if a person's eligible for cisplatin with kidney function.
Okay, thank you. I know we're a little bit over, and I want to respect your time. So thank you so much for this presentation and for answering the questions. Thank you everyone who was on today and submitted questions. We really appreciate your participation.
Thank you, everyone. Have a good night or day, wherever you may be. Bye bye.
Bye all.